Good evening, everyone. Welcome to this orthopedic teaching session organized jointly by the FRCS Mental Group and Orthopedic Research UK. I'm Firas Arnaout and I will be moderating this session. And to help me is Ruth, the Head of Education from OR UK. The speaker this evening is Mr. Mahaluxmivala, and he will be teaching us about total knee replacement, the main difficult concepts. He will make them easy for us all. The presentation is pitched at FRCS level. Mr. Mahaluxmivala is a consultant orthopedic surgeon at the Princess Alexandra Hospital in Harlow and the Ramsey Rivers Hospital. His special interest is in lower limb joint arthroplasty, including revision surgery. He completed his training at the Royal National Orthopaedic Hospital in Stanmore and has done his fellowships in North America. He's a co-director of the formerly known Royal College of Surgeons FRCS course, and he now runs it as Mahaluxmivala Chairman FRCS Ortho Viva course. It's a very popular course. Many candidates who passed the exam have been through this course. Mr. Mahaluxmivala is an invited speaker on several national and international conferences. He's a faculty of several teaching courses, including knee replacement courses at Harlow and Cambridge, basic sciences course, and various other instructional courses. Mr. Mahaluxmivala has been working with us actively on the FRCS mentor group since its inception. And he's been involved with us in online teaching and webinars for the last 2.5 years. So we are very pleased that he's kindly accepted our invitation to present tonight. As you can see, the session includes a lecture presentation, which Mr. Mahaluxmivala is very keen to run it interactively, which worked very well in the past. There will be some case discussion. We'll discuss the concept, followed by some case discussions, and at the end there will be 3 MCQs to test that you've been focusing with us during the session. If you have any questions, please feel free to ask in the chat box. The chat option is at the bottom of the screen. And also, after the session, there will be a hot seat practice. The Viva practice is not recorded, and you are all invited to take part. So anyone interested to take part, please raise the hand symbol that you find next to your name. And the participant list, there is a hand symbol which you can raise, so we know you are interested in Viva. And it is on first come, first serve basis. Obviously, we'll ask you, you'll be entitled to have CPD certificates, and we'll ask you for a survey also, and Ruth will be already been in touch with you about this. If you miss any part of this presentation, please don't panic. It is recorded and will be posted on the FRCS Mentor YouTube channel and OR UK website. Without further ado, I will leave you with Mr. Mahaluxmivala to start.
Lovely. So thank you, Firas, for that very kind introduction. And I would first like to thank Ruth Threadgold and AR UK, but especially you, Ruth, who really has the pulse or has a finger on the pulse of all the orthopedic education in the UK. She really runs her courses like clockwork, and we need to thank her, or everyone who has passed needs to thank her for all the courses she runs. I'd like to thank her very much for that, and I think everyone who's passed needs to thank her, and I want to thank her for the invitation. As my affiliation, I have been involved with the Cambridge Basic Science course since its inception. It's about more than 10 years with Vikas Kanduja, and also obviously it's AR UK, so with Ruth. In my capacity as training for London and East of England, I will be involved with Ortho Hub and East of England websites, and all these I'm going to give talks on, which I think only help to improve education in the UK. However, I really feel that the FRCS mentor group, I need to thank them for the invite, and I'm very pleased and proud to say I've been with them right from this inception. I didn't realize it's 2.5 years, but all these webinars which are happening now during the Corona lockdown, this group had started and had the foresight to see online Zoom teaching for 2.5 years. And I think all of them, all the senior mentors who have contributed tirelessly every Wednesday with teaching sessions, all video recorded, I think need to be commended for that. And in addition, of course, therefore, with this new collaboration between AR UK and FRCS Mentor Group, I think it's excellent for orthopedic education and training, especially for the FRCS Orth International, both in the UK as well as abroad. So thank you, Firas, for that. So can I carry on with my talk, Firas? Yeah?
Yes, please.
So the way I've planned this, and I would like to do it, is that we'll start with common FRCS Orth questions. We'll talk about terminology. And in that, the terminology, which I think you all get confused with, or most of the time people use interchangeably, is, when you use words like constraint, when you use words like stems and augments, and then we'll have cases. Ruth had very kindly put together this format where we have cases, and that's good, but I want to do it leading on from this lecture. And it's very important that in knee replacements or hip replacements or common topics, we all feel when we go for the exam as candidates, oh, we know that, let's concentrate on something else. But the issue is, can we truly verbalize that concept? Okay, so it's not for me to talk on this, it's whether you all can talk. So I don't mind going slow. And I think, as you all have realized as candidates, for topics like hip and knee replacements, you need to have a 7 or 8, but you can't get there unless you verbalize your concepts clearly at the basic level. So that's what I want to try to do for this 45 minutes or half an hour. And I don't mind, it's interactive. I don't mind skipping slides. I don't mind repeating slides, but I want everyone, whoever has attended today, to go away with at least a 60% retention information. Okay, that's my goal. So let's start with the common FRCS Orth questions. Firas, if we can, and just for everyone in the audience, I feel making it interactive is more or less what you will want to know as to what we are doing in the exam. So if you don't mind, I may ask Firas to nominate, or if someone volunteers, to just, I'll ask a question. You give whatever answer you want to give. It doesn't have to be right or wrong. It just starts to introduce that concept to me, and then we can take it forward. So I hope that's all right, Firas. And if you don't mind, is there anyone who you would like to nominate or volunteer?
Sure. We have Joey here who's interested to be your sort of candidate for this casual interaction. Yeah.
Thank you. Hi, Joey. Can you hear me?
Yes, I can hear you. Thank you.
So Joey, and once again, for all of you all who are in the audience or all of you all preparing, if you all are practicing vivas with each other, ask yourselves and tell yourselves, Joe, that are you sitting on the basic science viva table or the adult reconstruction? Okay. Yeah. Okay. So in this way, I'm telling you that we are both sitting, or I am grilling you, or I'm asking you, and it's your exam, and we are on the basic science viva, not the adult reconstruction. Okay.
Okay.
And tell me, you've been involved with knee replacements, haven't you, Joe?
Yeah.
Yeah.
Yes.
So and I'm asking you this as a candidate, not as Joe. So as a candidate, so can you tell me, on the left is a femur, and what do these two lines represent? So tell me, what does this line represent?
This line represents the anatomical axis of the femur along the longitudinal axis of the bone.
And what does this line represent?
Is the mechanical axis of the femur, which is a line connecting from the center of the head of the femur, center of rotation of the head.
Can you tell me why this is important when we are doing knee replacements? Either adult reconstruction or on the basic science level.
It's important to calculate the valgus angle to have a precise perpendicular because my aim in total knee replacement is to restore the mechanical axis of the knee. So my distal femoral cut has to be perpendicular to the mechanical axis. Because I am using an intramedullary guide, which is the anatomical axis to the femur, I need to have 6 to 7 degrees valgus.
Perfect. So I would say, Joe, you answered it excellent. And at the same time, just now for clarification to everyone in the audience, when you're asking questions like this, answer exactly like Joe has, but I'll just put it together for everyone. So the first thing you say is, yes, tell the examiner, that the left, this line is your anatomical axis. Tell your examiner that this line is the mechanical axis. Then say, these two lines are important in knee replacements because, and always say, my goal of knee replacement is what? So we can tell the examiner, and for everyone, my goal of knee replacements is to place my femoral component, and use these words, place my femoral components perpendicular to the, which axis, Joe? Mechanical, right?
Mechanical axis.
Correct. So say that that's your goal. Then say, however, practically, when I do my knee replacement, I use an intramedullary jig or an intermedullary rod for my jig. And hence, I do know there's a difference between these two, which is between 5 or 7 degrees. And hence, I dial that and use these correct words, which are impressive. I dial that difference into my jig, which gives me my correct valgus cut angle. So the 7 to 8 on this question would be, Joe, you were absolutely there. And that would be the words you want to use is, most of the time, 90% is intramedullary jigging. I do know that my aim is to 90 degrees to my mechanical axis. Hence, I want to divide it between, I know the differential between the two. Not leading up from one to the other, it's just introducing different concepts. So let's start on this one. Zubin, you're the candidate and you're sitting on the basic science viva, again, not on the adult reconstruction. And I show you this. So what is this, please? Can you tell me what this is?
This is a jig to do the referencing.
Yeah.
Okay. The numbers at the bottom, starting from 2, 3, 4, and 5.
Correct.
Are the ones we adjust to get to achieve the posterior referencing.
That's fine. Thank you. So in other words, this is the correct word for this would be, this is a sizing jig for the femur. Now, everyone for the exam, right? I want to give you this point that in the vivas, Zubin and everyone else, you will be shown a photograph, and that's what is called as a setting question. Now, for a setting question, there are no true marks. Now, whether, Zubin, you got it right or wrong, I would guide you to what it is. So let's suppose you didn't get it wrong. I don't want you all to panic, okay? So it's just a setting question. So I'm telling you, this is a sizing jig for my femur. And I'm telling you, Zubin, that there's one hole saying right lateral here, and there's another hole saying right medial. So they're not at the same level. And any modern jig will be at a different level. Can you tell me why that is, Zubin?
So these holes are at different level in order to achieve a rectangular gap. Mm-hmm. Because if we don't use these holes, then we can put our component in internal rotation.
Mm-hmm. So why do you want that external rotation? I agree, you want an external rotation, and all modern jigs will incorporate that. But why do you want that, Zubin?
It is due to the anatomy of the posterior condyles. Mm-hmm. It is because I want to achieve a rectangular gap.
Okay, so I would say, Zubin, for this one, start by saying, and I'm giving you the answer to introduce the concepts. So the first thing you say that this is a sizing jig. It doesn't matter if we knew it or not. Then say, yes, all modern jigs will have it at about 3 degrees of giving a degree of external rotation. You agree, Zubin? That's what the jigs will do. Yeah. Then you say, remember, the same way, try to answer all questions. Let's say it's a nailing or a femur replace or a hip replacement, is what is your goal? So say, my goal in hip and in knee replacements is to balance my flexion and extension gaps. Is that correct, Zubin? Is that a good phrase?
Yes.
And then say, I need therefore a rectangular gap, both in extension and in flexion, right?
Yes.
Then say, however, when I do my knee replacement, so this is what, when I do my knee replacements, I do know that anatomically in the virgin tibia, so in an uncut, in your tibia, in the world tibia, do you agree that there's a 3-degree varus slope in everyone?
Yes.
Yes. Yeah?
Yes.
So you can say then the virgin tibia, there's a 3-degree of varus. However, when my goal, like what is your goal? To balance your flexion extension gap. However, in practice, all surgeons will cut your tibia, you agree, at 90 degrees to the long axis of the tibia, not at 3 degrees, correct?
Yep.
And hence, I need to dial in, and that's the correct word again, my 3 degrees, which is done on my femoral side by external rotation being incorporated. Right,
Okay.
Zubin?
Yeah.
So once again, you were right in what you were saying, but just keep in mind that it is the reason for that is the problem or the issue on the tibia, right?
Okay.
Most surgeons will say your answer was very good because you immediately said it's the getting your rectangular gap. However, and this is the however, is that most surgeons, when I ask this question in my course or in my course in Cambridge or in wherever I teach, they always say it's due to external rotation for patella tracking. It is, but that's your secondary benefit, okay?
Yeah.
The primary reason is this, what we've talked about, and then say any further, and that's what I wanted to tell you, any further correct rotation for that knee will depend on the femoral compared correct rotation. And for that, Zubin, what are your lines? You'll say, I do know that I use different lines, correct? Which are?
Yes. With a wide size line.
Yes.
And the epicondylar axis.
Yes, and the posterior condylar axis. Yeah.
Yeah.
So I hope I've introduced this concept again, that very simply, no confusion. If any part of this is introduced to you in the basic science or actually in true life, this is what you're going to say. So your 3 degrees on the jig is for your tibia. Any other, and we have to make sure you get correct rotation. And we do know in life, we use 3 axes, and all of you all in the audience, and Zubin, you remember the answers would be, the common one would be what? 90% or 80% surgeons would use?
The epicondylar axis.
Epicondylar is
posterior axis.
posterior condyle, yeah, correct. So most of us will use the posterior condyle. If, however, there's any problem of wear, which happens in a, for example, a valgus knee, we will not use that. Then we have to use another axis, and you can use the epicondylar axis or the wide size line, right? Happy with that, Zubin?
Yes.
Okay. Now, Firas, is there anyone else volunteered, or can I carry on with Joe or Zubin? Just, it's something like this. So.
Yeah, we have Muhammad Al-Gawadi who wants to chat also.
Okay, so if you don't mind, can I see? So Zubin, thank you very much. That was fine, absolute pass for what you've said.
You're welcome.
Can I?
Muhammad?
Yes, with you.
Firas, is it clear? Are we seeing both of me and the exact and the trainer? Is that all right for you?
It's all clear. You can see your presentation. Very nice illustrations to display the concepts. Okay. And we can see yourself also when you talk. Yeah.
Thank you. So, Mohammed, thank you very much. Now, once again, this is you're sitting with me on my basic science Viber table. Mm-hmm. Yeah. And I'm asking you a question that I resurface all my patella. So I'm asking you, what am I doing here? Can you answer me?
You are sizing the patella.
Correct. So I tell you, thank you so much. So once again, for everyone, this is my setting question. All right, my setting question. My setting question means I'm not going to mark you on it. Now I'm going to ask you a question that I resurface all my patella, and you've joined me as my consultant colleague in my hospital. And I'm asking you, are you going to resurface all your patella or not, or some of them? Please tell me what your answer would be and what you'll do.
This is a controversial issue. I worked in a hospital where all the consultant don't resurface the patella. Okay. Another hospital I worked with a consultant. He is resurfacing all the patella.
Excellent. So what will you do?
But in my opinion, I will go for resurfacing the patella.
Why?
Because it will decrease the risk of development of anterior knee pain after the knee replacement.
Okay. Yeah. Thank you for that. I agree, Mohammed. At least this is a common question which most people maybe ask, and it's a very difficult question to answer. Do you agree?
Yes.
Yeah, because you've been an examiner, or you've done so much training. Do you agree this is a reasonably common question which stumps people?
Yes, it's one of those difficult questions because there isn't a real one correct answer for it. And the candidates just need to have one answer and back it up, basically. That will be generally, but I agree with you. This is
a question which is difficult to answer from all our sides. So I would like to introduce this concept that in orthopedics, go by 3 studies and use these terms all the time. Mohammed, use this term for trauma, for hip replacements, knee replacements, nailings, etc.
Yes.
What we look for is long-term implant survival studies. Use this phrase, okay? So you can say that's one. The second studies we look into is patient-reported outcome measures. You agree, Mohammed? That's all we want to know. And the third is laboratory-based studies. So this is a good opening line. So if you know there's a controversy of topics, for example, you're right, there's a controversy in the world for knee replacements, for patella resurfacing. In hip replacements, they may be cemented versus uncemented. It's best to start off by saying very clearly, I do know that there's a controversy in surgeons in the world. So Mohammed, that was correct to say. Second is say, however, because I practice evidence-based medicine. Are you happy to use that word, Mohammed?
Yes, yes.
Yeah, so you can say, because I practice evidence-based medicine, I do know that at the present time, there's no true literature which says there's a difference in long-term implant survival studies if you resurface or not. You can say there's no true patient-reported outcome measure studies which say yes or no, and there are no laboratory-based studies. Okay, so you can start with that. So start with the usual line, then say, however, because it's a basic science viva, you can say, I do know, however, that the patella is important for what? For quadriceps function. All right, so that's your second phrase you'll use, that I do know the patella is important for quadriceps function, and say, I do know that the height of the patella is important for that, to optimize that. Correct, Mohammed?
Yes, yes.
So happy with these statements? So say the basic science, I know the patella is important, and I do know the height of the patella is important for that. Then proceed and say, let me draw you a diagram of the forces around the knee. So you draw a patella, you draw a quadriceps tendon, and you draw the patella tendon, right? And then you say, I like to resurface the patella as I want to recreate the height to optimize quadriceps function. Or you can say, I do know that recreating patella height can help in quadriceps function, but it's not borne out in studies. That's why I do not do it. So the answer is not whether you do it or not. It's whether you do know what the role of the patella is. You get what I'm saying?
Yes, yes. This is very difficult.
Yeah. But you get my concept that it's a basic science viva. And it's, you know, all of you will argue that he failed me because he's a resurfacer, he failed me. No, nothing. It doesn't matter what you do or not. As long as you know there's a concept which is controversial. And secondly, I'm leading you to the basic science part of it where you should know. Do you agree, Mama, that everyone should know why the patella exists? And you should know that the height is important, you know, for quadriceps function, right? So that's all the concept is. So happy with that?
Yes, yes.
So that's how you'll answer resurfacing, yes or no. Right. So thank you, Mohammed. If you
thank you, sir.
Now, this is an easy one. So Mohammed, I may just stay with you. You joining in Myanmar hospital, would you use a cemented or an uncemented implant?
Almost all total knee replacement I was involved in was cemented.
Okay.
Because
stick to my three words. Just say that at the present time, the world literature does support, long-term implant survival studies, correct, with cemented implants, right?
Yes.
You can say that. You can say that, yes, they are very clear, good documented patient-reported outcome measures, and hence I use a cemented knee, right? So here there's no controversy at the present time. 90% of surgeons would be using cemented implants for the reasons which I gave, yeah?
Yes.
And which cement would you use? Which type of cement? You can say, let's keep in mind, just remember the word. Once again, this is to get a 7 or 8 for everyone in the audience. Say, I will use a cemented, and here I'm cementing, and you say the word is a standard. It's not say, I'm sorry, it's a standard viscosity cement. Okay, so you can say it's a standard viscosity. In other words, you do not use low viscosity cement in knees.
Yes, but sometimes we use medium and sometimes we use high viscosity.
Yeah, but the correct word, Mohammed, if you just to let you know, is standard. Yeah. So,
yes. Okay.
So in the world, we have standard viscosity. That's exactly what you are right. We use standard, but we never use low. So you know that, use low in hip. So say it for now. Happy with that?
Yes, happy.
And the gold standard, therefore, at the present time, supported by evidence-based, is your cemented knee.
Yes.
So now, everyone, this leads nicely to a next. I'll tell you how I would like this concept on this question answered. So this nicely leads to which knee would use and why. Okay. So I would say, and I'm just giving you an example, I use a posterior substituting total knee replacements, and you can use the word, you can say the name, example PFC sigma. It is cemented, and I do a patella resurfacing. Or, and I'm using the word or, you can say I use a posterior retaining total knee replacement, which is a Zimmer knee, you can say that, or a triathlon knee, which is striker. I don't mind, it doesn't matter, but just say what you use. It is cemented, but without patella resurfacing. All right, and then, but you have to say why you do it. Okay, so say the reason I use either, it doesn't matter, is I need a knee system. And this is what I want you to say. I need a knee system which can cater for all anatomic variants. It's a good phrase to have, Mohammed. So you're saying that I want a knee system which can be there for valgus knees, varus knees, etc. Happy?
Yes, we need to memorize.
Then I can say, yeah, then I can say I want a system which incorporates stems, augments, and offset trays for complex knees. You want one system leading to another. So most of the modern systems have that, but that's the reason we use it, right? Third, you can say, I want a knee system which incorporates my philosophy of balancing. And we don't have time because I only have 45 minutes, but I'm just introducing that is a good time to know in your mind, in your preparation, that you have 2 or 3 lines on how to balance a knee, right? So you know you're going to prepare that moment, okay? So you can say I need a knee system which allows that. Then say I need a knee system which got a proven track records for long-term survival, and this is where you can quote your NGR for the knee or the hip you want to use. And then say I need a knee with a proven track record for outcome measures with a high ODEP rating. So all this in 30 seconds to 1 minute, you've scored a 7 or 8. Yeah, rather than just saying, oh, I use this and not knowing why. So I've tried to distill out, I've tried to put you 6 points on which you talk on for joint replacements. Happy with that, Mohammed?
Yes.
Okay, thank you. Firas, anyone? Thank you, Mohammed. Very good. Thank you for that. Anyone else, Firas?
I think this is the gold standard, the method of how to answer this question about any implant, isn't it? Any implant you use, you could use this method of answering that question and getting the top mark rather than waffling around. So yeah, so next, Atif is the next one.
Okay, so now on my next one, I'll like to introduce terminology. So far we've introduced a concept. I can't, like I said, there are many other concepts like posterior substituting, retaining, gap filling. We can do it at the next time, but at the present time, let's go on to terminology. So the 3 terminologies I want you to know is constraint, stems, and sleeves and augments. Okay, so happy with these 3 phrases. So anyone for me, for us to just ask?
Yeah, Atif.
Do you think there's a difference tell me what you understand by constraint, if you don't mind.
Constraint means that the implant providing the stability to the joint.
Correct. That's it's a very simple, correct way of saying it. And therefore, just tell me how you go high up in constraint. What are your levels of constraint in knee replacements?
First one is the unicondylar, which are least constraint.
Sure.
And then in the bicondylar total knee replacement, the cruciate retaining is the first, and then cruciate sacrificing, that is the posterior stabilizing.
Yeah.
And then varus valgus constraint, and then hinged knee.
Fantastic. So that's a very good answer. Firas, you agree? He's straight away onto a higher level of 6 directly and use the correct words. So Mohammed, stay there. But as for the remaining audience, I just want this concept to be there that I know even in the NGR, they talk about posterior retaining and PS being different in constraint. Truly, and I'm looking at the true knee kinematics, the mediolateral stability should be the same for both. And why I say this is important as a knee surgeon, that I'm not introducing the concept now, but let's say you were talking about substitute of a PS or a CR knee, a retaining or substitute knee. Don't say that I will use a posterior substitute knee because my balance was not good. My message I want to give is balance has to be perfect for mediolateral for both types of knees. So don't fool yourself or don't fool the examiner by saying, oh, my balance is not good. Let me use a PS. That's the message I want to give, right? So that's one. And the next level up is the correct word for everyone. I want everyone to use the correct word, which is a partial varus valgus constrained knees, okay? And this is the terminology which is correct. And the next level up will be a hinged, fully constrained or a hinged rotating hinge knee. So tell me, when do you need more constraint, Mohammed? When do you want to have more constraint?
It depends upon that our ligaments are intact or no. Okay. The flexion extension gap which we are doing, by doing that, if we can still retain the stability of the joint, then we will not use the constrained knee. If we can't retain, then we use.
What about bone? Will bone loss interfere with that or not necessarily?
Yes, bone loss, soft tissue loss, both will be coming.
A good point. I mean, good you mentioned that, but now I'll give you a point which is important for the whole audience to understand. As a knee surgeon, I'll tell you, and also on your level. So the first thing you say that when you need more constraint, use a high constraint. And it's done only for collateral ligament laxity or an issue, okay? Or a laxity issue. It's not for severely deformed knees. So when you see a severely deformed knees in the clinic, really deformed, you may have a judgment that you may have to go to a higher constraint, but you cannot make that final answer unless you restore bone stock. Mohammed, that's the point I'm making, okay?
Yes.
So the next question, and this is your basic science viva, and I'll just move on because of speed. The reason why you get a higher constraint in a varus constrained knee, which is your next level up from a normal posterior stabilized knee, is what? Mohammed, do you want to answer it quickly? What is this? This is your box?
This PS knee.
Yeah, but is it a PS knee or is it a
varus constrained knee?
Exactly. So for everyone in the audience, a PS knee will have a block which is only so far. So the word you'll have to use is how do you get more constraint? And this is important in the viva in case a implant is shown to you, Mohammed. He will say, I do know this is a varus constrained knee because it got a higher box, yes? And it got a corresponding higher spine of the insert, rest, with a reinforcement pin. So what are the three aspects which give you more stability or more constraint is a higher box, a corresponding higher or longer spine. The spine is also broader and it got a reinforcement pin. Yeah, forwards, right, Mohammed?
Yeah.
Have you? So next we move on to the truly constrained, which is a loss of collaterals, which gives you this. Firas, I've timed myself. I'm just about 34 minutes. Can I go 5 minutes more on this?
Yes, you can, of course.
Thank you. Can I stick with Mohammed because you're answering quite well?
Yeah.
Mohammed, now I'm going to introduce a concept called, so I've introduced so far for the audience, constraint, right? And we very clearly said when you need constraint is only for a ligamentous laxity issue. And now I'm asking you a question that I'm showing you on your basic science viva. Forget about this. I'm just showing you this. So I tell you, what is this? This is called a?
This is spine or the stem.
Stem. So everyone in the audience, the correct word for this will be a stem. So I'm asking you, Mohammed, not in this because it's a rotating, but generally, even on a normal knee, when I just want to use a stem, why do you use a stem and when do you use a stem?
We usually use the stem in a highly constrained knee.
Fantastic. So you need a stem whenever you're going up in constraint. So everyone in the audience, Mohammed's answer is the first answer. So whenever you go up in constraint, I will use a stem. Happy with that, everyone? And you, Mohammed, correct. So that's your correct answer. So the answer is whenever I go up in constraint, I will use a stem. Thank you. Next, the next one, Mohammed.
Next one is that when there is bone loss and we need to stabilize the implant.
Correct. Now, correct.
And if there is bony defect, we have to pass that bony defect also.
Lovely. So the next, so first answer to everyone is when I use a stem is when I want to, whenever I go up in constraint, I will use a stem. Then you want to verbalize this concept, Mohammed, that say the reason stems are used is that you tell the examiner that by using any stem, either on a rotating hinge or on a semi-constrained knee or on a normal knee tibial play, I increased my surface area of the construct. Happy to use that phrase, Mohammed? I've increased my surface area of the construct. And say the reason I want to increase my surface area construct is by doing that, it dissipates, the correct word is dissipates the forces on the bone implant interface. Happy with that?
Yeah.
Yeah. So the increased surface area of your construct dissipates or takes away the forces from your bone implant interface and prevents loosening. Yeah. So that's the reason you use it. And say, therefore, the conditions I'm worried about is when there's bone is not of the best quality. So you can say, and that's because, so whenever you use a high constraint, bone deformed tibia not large enough for the next step up, which I'll come to, poor bone quality. And I do it, I as a knee surgeon, because I take on complex knees, I do it for all post-tibial fractures. All right, Mohammed, happy with that?
Yeah.
And next, I'll finish with this, is now you see this knee, you agree it's very deformed, everyone? Mohammed, you agree? Deformed knee? Severely varus? When a patient walks through your door, do you agree it's going to be a severe deformity?
Yes.
Most of the time when I ask my registrars and fellows, their first line would be, oh, this is a severe deformity, it'll need something, it'll need the first answer they gave, it'll need a varus constrained knee or something. No, it might. I'm not saying don't keep it in your background of your theater, but the first, you can't judge that because this issue is due to bone loss. You agree, Mohammed?
Yeah,
so now, do you agree just putting a stem here will not help that bone loss? You agree? Yes?
Yeah, okay.
You need something else. So the word I want you to use and I want the audience to use, you will use two words. I, for the last 10 years, use something called a, what do I use? A metaphyseal sleeve. Yeah? So see this here? This is a metaphyseal sleeve. Or you can use the word, I will use augments, which come in the word of steps or wedges.
Okay.
Yeah. So when you want to recreate or you want bone loss to be better, don't say, if it's mild, you'll just use a stem. Correct, Mohammed? Like you said?
Yeah. Yeah.
If it's severe, you will use the word tibial metaphyseal sleeve, or you will use a step or an augment. Yeah, augment.
Right.
But augments, I think we as knee surgeons have gone a little away from that.
From Mikhail Jain, he wanted to clarify the rotational element on the femur with you. And he you directly, I think, just to convey his message clearly rather than me passing it on.
Sure.
Okay, want to talk?
Yeah, okay. So you mentioned the can you hear me, Mr. Mahaluxmivala?
Yeah, thank you, Mikhail. Very well.
Yes, we can hear
you. Okay, yeah. So you mentioned about the dialing of the external rotation on the femoral component, which is based on the inherent varus of the tibial plateau. Is that correct?
Yeah.
Yeah. So I don't quite understand that a varus valgus deformity of the tibial plateau is an angulation deformity. How you can compensate that by correcting the rotation component on the other aspect, or whether it's based on the altered anatomy of the femoral condyles, which is why you need the external rotation.
Yeah. Good. Yeah, good you answered that, Mikhail. The reason is, this is all comes down to traditional knee replacement philosophy. Now, when you, if we have to accept that a normal virgin tibia of anyone, right, is in 3 degrees of varus, do you accept that at least, Mikhail?
Yes, yeah.
Yeah. Now, that means your collaterals, right, are inherently at a different tightness in you because your, your varus is of 3 degrees, right? Correct? Yeah. Now, when we do knee replacements, we want to balance our extension and flexion gaps, right?
Yeah.
Now, your flexion gap, right? Your flexion gap depends on what? Do you agree your flexion gap depends on your posterior femoral condyles, how much you cut and where you cut? Do you agree with that?
Yes, I do.
Right. So now, imagine if you don't cut. Now the next point, therefore, to clarify your point, is when you do your tibia cut, do you agree that we cut the tibia not in 3 degrees because most people's can't be, our x-rays we want to do it 90 degrees. even though it's not the virgin tibia, because we surgeons cannot be so good to cut at 3 degrees. You agree with that point?
Yeah, correct. We cut it perpendicular to the long axis.
Yeah, and that is 3 degrees away from what the normal human nature has given us, correct?
Yeah.
So therefore, in flexion, the only way to balance that part is to cut your distal femoral condyles in a different amount. You agree? Because you've cut, because now you've cut at 90 instead of 3. So those people who propagate this new concept called, anatomical knee replacements, which is, they say we'll cut it doesn't matter, you can cut your tibia here and there. The answer is that we don't have the skills. Yes, with robotics coming in, we may be able to, but as a surgeon, I've done thousands, and even my colleagues who've done even more thousands than me, they can say they'll never cut to 3 degrees. You see what I'm trying to say? So if we are cutting to 90, we need to recreate that. So thanks for asking this question, and I hope I've clarified it to everyone in this manner.
Okay. Yeah. Okay. Thank you.
Yes, thank you. That was very clear. Thank you, Mikhail, for your question. Question that came in from Rajan. He's asked, what's the difference between a sleeve and a cone?
Yeah, I would say I leave this to who's asked this?
Rajan.
Yeah, Rajan, I would say, Rajan, thank you for asking this. If you ask at the FRCS auth level, there are some questions which we need to know, and there are some questions which I call fellowship level questions. Now, Firas may agree with me that truly, knowing the difference between cones and sleeves is something which I know as a surgeon because I do it in complex surgery. The difference is that the metaphyseal sleeve incorporates the entire metaphysis, all right? And the stability and the ingrowth happens because of this metaphyseal fixation throughout the metaphysis. And the cone will be used within that area, but it can be used as a semi-cone or trabecular metal, which can also incorporate to make up bone issues, not necessarily only in the metaphysis, all right? But I don't think, I'm answering this as a knee surgeon, but Firas will agree that as a concept for FRCS auth, it's not an important concept. All you know is that cone can be used interchangeably, but it can be used also for only parts of bone which need to be looked into.
Yeah.
But I only use a tibial metaphyseal sleeve if I have to.
Remind everyone, when you go for the FRCS exam, you test it at day 1 consultant level. And day 1 consultant is unlikely to be asked to do any replacement with cones and sleeves and things like that. But you're expected to know the principles, obviously, and you say
exactly
to supplement this or with the cones or sleeve. But I wouldn't expect that you'll be grilled into this any further.
Yeah, that's why I don't want to take it more now for everyone, for us. Just as a concept, it's done for bone loss. And I think that's a good enough answer.
Okay. There's one more question from Noman. He said, I think you went through this in your presentation, but he wanted clarification on how do you define constraint?
How do you
define constraint? What is exactly constraint?
The inherent stability given by the implants, irrespective or dependent on the soft tissue envelope. All right.
Yeah.
And therefore, for that, I would say you need to know that the levels of constraint, and you can say after the posterior cruciate retaining and you're substituting knee replacements, which are the standard knee replacements in the world, the next level up for constraint is a partial varus constrained knee, where the constraint is higher, and that is, and the next level up would be a hinged knee.
Yeah, I think a lot of questions here are towards revision because it's difficult concepts. But again, if you get in the exam, if you get to that far, you definitely pass the question. I wouldn't worry too much about that. So next, I have another question about the tibial slope and how important it is. Is that someone, Nabard, is trying to wanted to be clarified whether increased tibial slope increases the flexion. Is it how much is it recommended? 0 or 3 or 7 degrees?
Yeah, good question. Can I? Who asked that? It's a very good question, and I can answer
from
that.
Nabard. I mean Nabard.
So Nabar, thank you for that. Let's start first by, because the target audience of this is FRCS and passing, but obviously it's an important, good concept to have as surgeons, because whatever we talk about is in real life. The answer for this slope, right, is, first of all, you have to say that if you're using a posterior cruciate substituting knee, you do not have to give a slope, because the post and the cam meet together at a particular flexion, and you get a reliable or reproducible flexion. Okay, in a posterior cruciate retaining knee, yes, there's a degree of slope needed to recreate your flexion. Now, I am a true posterior cruciate substituting knee surgeon, and all of us in Harlow are, because of Paul Allen's and our philosophy of posterior cruciate knee only. Now, the reason why we don't give slope in a PS knee, and you don't need a slope in a PS knee, is that you agree that when you're cutting your tibia, you put your jig on the front of the tibia. You agree? Yes? Yeah. Now, if you know where the true front of the tibia is, then when you cut your proximal tibia, you get a perfect cut, which is not in valgus or varus, right?
Yeah.
But in real life, when you put your jig onto that front of your tibia, you agree your patella tendon, your tibial tuberosity, everything is biasing you not on the front, true front of the tibia. It's biasing you more medially. Yes?
Yeah.
And therefore, if you put slope, right, and then you cut, you are propagating or making your valgus varus cut worse. So you choose your two devils. Do you want to have your valgus varus cut worse? No, because posterior laterally or posterior medially, if you have a slope, that becomes worse. So therefore, I don't go for a particular slope, but make sure that we don't have any upslope. Okay, so the answer to your question is, it makes a difference in the two knees you're using. In a posterior cruciate substitute knee, you don't necessarily need a slope. And the reason why that could be advantageous is that you're cutting on the front of the tibia, but you don't want to cut and give you a valgus varus issue with your cut. But in a posterior cruciate retaining knee, yes, there's a degree of slope required. But I'm telling you, as a practical knee surgeon, reproducing slopes, saying 3 degrees, 7 degrees is a lot of, you have to reproduce some slope, but getting it exactly how much is not reproducible unless you're using robotics or computer guided. That's my practical answer to you.
That's lovely. Nabard, is you happy with the answer?
Yeah. Thank you very much. I can.
Any further clarification? You okay? Yeah, lovely.
Yes. Thank you. Thank you.
Thank you, Nabard. So we have next question from Atif, and it is a reasonable question. I think he wanted to make sure he's using the right terminology when he answers. He wanted to know the difference between constraint and conformity. They are obviously completely two different aspects, so I think he wanted them clarified.
Conforming is a very important word. I didn't want to introduce it here because there are too many concepts but that would come under the heading of posterior cruciate substituting versus retaining knee. Now, in that, that there are two types of polys which are different in the retaining and the substituting knee. You agree? Yeah? In the retaining, you do not have a cam and post, right?
Yes.
And correct, you don't have a cam and post in your retaining. Now, in your retaining knees, when originally 30 years ago, 20 years ago, that design was called a flat design. You agree, Atif?
Yes.
Yeah. And we realized that flat designs did cause more wear, especially in the CR knees, right? So over years, the new poly is called a conforming poly, right? So the word conforming is the word you use when the poly is given to you in your hands, or when you're as a practicing knee surgeon, I do know. So you can say modern polyethylenes are conforming. So you can say, when you pick it up, you can say this is a modern poly because I know it's conforming. While the old ones would have been flat on flat designs, which were not good. So that's where I would like you to say. So the message would be conforming is a word for polyethylene. All modern knee systems have a conforming poly, both for PS as well as CR, but it's more important for your CR part of it because in the old days, the flat CRs wore away more. That would be my answer.
Thank you.
Happy with that, Atif?
Thank you.
That's lovely. Thank you very much. I think we have Abhishek who wanted to ask a question about the longevity of the constrained implants. I'm not sure exactly what he wants to know about it and how relevant it is for
I think for us, it's relevant to a degree that, let's suppose examiner has shown you an exam, X-ray with a, you know that it's a constraint implant, right? You see it, or he gives you a polyethylene or an implant which you know is a constraint. He may ask you that why does this not last in studies as long as your normal knee? Yeah, that will be your basic science level. And therefore you can say that as the constraint goes up, the problem happens is that the same words I used before, that the forces on the metal bone interface become worse. And I need to dissipate those forces. And therefore, if I'm using constraint, I need longer stems to dissipate those forces. And therefore, I do know that the long-term survival of them may not be as much as your primary knees. But with modern knee techniques, with modern knee metallurgy, we are hoping we'll get there. So that will be a fellowship level. But what he was asking for, you need to know that the higher the constraint, the more you'll have forces on your, correct word, metal bone interface or cement bone interface, whatever you want.
Thank you. Shamsi Hamid asked questions about anterior and posterior referencing. He wanted this also clarified. What's the difference between anterior and posterior referencing?
Okay, that the first thing to tell someone, and once again, Firas and Fawd, you'll agree that no one is going to ask this question directly at the FRCS auth level, right? I mean, it's a more practical knee surgeons rather than a concept. But I think it's important to know because all of you in the audience are going to be doing knee replacement. I mean, you teach good concepts. So the first thing to say is anterior and posterior referencing. Both of them reference off the jig, right? This is your jig. Both of them sit on your posterior femoral condyles. So that's the first message I want to give everyone, which everyone gets confused. So the lugs of this will sit on your condyles. Happy with that, everyone? That will sit there. Yeah. Second is that the outrigger, you know, the front part will fall on the front of the femur. Yeah, that's on your anterior cortex. Now, the issue of anterior and posterior reference only becomes an issue if you're between sizes. So if you're a straightforward 3, it doesn't really matter whether you've done a posterior referencing or anterior referencing, all right? Because you're going to be using a 3 implant. And with modern knee systems, with more and more sizes coming in, this issue of anterior and posterior reference is becoming less of an issue. So that's the fundamental message, okay? But but still, in posterior up referencing, what we are saying is when your outrigger falls on the front, you see that when it falls on the front of the femur, I'm sorry, it wasn't part of my talk, that's why I don't have it to show you, but it falls here. Where it falls gives you a number. Let's say it falls here and it says it's a 2. It's not an issue, but what happens with your between sizes, that's when you have to decide whether you want to violate your back of your knee, that's a posterior part of knee, or the front of the knee. So with anterior down referencing, you're telling yourself that you will never notch the femur. All right, so I can repeat again. With people who use an anterior down referencing, you're telling yourself you will never notch the femur. If you're a posterior up referencing, which I am, that's why Zubin, who works with me, picked it up, that we in Harlow, everything is standardized. We only use posterior up. We are telling ourselves we'll never violate the flexion gap. All right. So the two concepts, and I think I'll stop there because I don't want to make it too complicated because I don't have slides to show you, is that anterior and posterior referencing only are important if you're between sizes. If you're anterior down referencing, you're saying you will never violate or never notch the femur. If you're a posterior up referencer, you're saying you will never go into or violate the flexion gap. And these are the three messages what I would say is important for this.
One more question from Noman. He's asked about cruciate sacrificing knee replacements. He said there are two types, anterior stabilized and posterior stabilized. Is that a concept that we need to worry about for the FRCS, or?
That you need, if you're sacrificing your posterior cruciate, then you will use the correct word is a posterior cruciate stabilized knee, where you use a box, and a cam. But there are some surgeons, and I don't know whether this is what he's asking for, they sacrifice the PCL, right? But they don't necessarily use a posterior cruciate substitute knee. They use a CR knee with a different type of a poly insert, which gives this degree of conformity and stability. Now, I'm very clear, all the 1,000 knees we do in Harlow, we have standardized, we get fantastic results, we stick to one knee. So we do only posterior cruciate substitute knee. But I think this is what he was asking about. But once again, for the audience, I don't want to confuse it by doing anything more.
Lovely. And one more question. Is congruency the same as conformity as far as knee replacement?
To a certain degree, you can use them interchangeably. But for the polyethylene, let's use the word conformity of the polyethylene.
And, okay, you wouldn't use congruency?
Yeah, it's a congruent design. It's a correct. You can use it more or less intermediate, but it's a design philosophy is congruent, and the polyethylene will be yeah.
Thank you, Mr. Mahaluxmivala. You spent all this time considering all these questions and answering them very nicely and carefully. Everyone who's attended, very appreciative of your efforts.
Thank you.
I got you got a couple of case discussions, isn't it?
Yeah.
And then after that, we'll put the MCQs, yeah? Sure.
And I hope for the audience, I think all the questions for us were very relevant. And I hope I didn't, I think for the people giving the exam or having the concepts, I think these were important, we touched upon. But all what I gave in my talk is what you need to have your delivery on, your verbalization. Yeah, so that's the message I would like to give.
Yes, perfectly level for pitch for the level of the exam. So just before we start, again, I would like to encourage you guys to make the best of this opportunity of having a Viva practice with the experienced examiner we have. So anyone interested in being asked questions, being put on a hot seat, please raise the hand symbol so we know you are interested. No one is judged, and as you see, it's everyone is welcome. So for the first case, we have Ahmad.
Hi.
Yeah. So he's the candidate discussing this case with yourself.
This is your adult reconstruction table, not your basic science, Ahmed. Can you hear me?
Yeah, I can, yeah.
And tell me, these are the x-rays which, and you agree this is a common scenario, you'll be shown difficult hip x-rays, you'll be shown difficult knee x-rays. So my remit of what we're doing now is just to tell you how to talk about a complex knee x-ray shown to you. Yeah, that's what I want to show you. So tell me what you see here.
Yeah, so so this is a plain radiograph of a knee. There's a AP and lateral view. Most of his abnormalities, the severe osteoarthritis with a significant bone loss, what seems to be to me on the femur component, specifically on the lateral femur condyle. Yeah.
Okay, so that's on your AP, right?
Yeah, that's right.
So stick to your AP and just tell me, so once again, I didn't hear you too well. So on the AP view, the most important abnormality, start with that is, sorry?
Significant arthritis, and there's a significant wear and bone loss on the lateral femur condyle.
Over here, yeah? This is what you mean?
Yeah, that's right.
Okay.
Yeah.
And do you think there's any bone loss on the medial tibia?
Yeah, I mean, it's difficult to correct, but there is some degree of bone loss as well.
Perfect. So that's the correct answer. So you'll say this is there. Would you comment a degree on whether it's a varus or a valgus?
Again, it's a deformed knee.
So the correct word would be it's subluxed laterally. Is that, are you happy with that phrase?
That's right. Subluxing laterally, yeah.
But to a certain degree, it comes in the realms of a varus knee. Do you agree?
That's right, yeah.
Yeah. So this is where you get confused sometimes with gross changes. So let's have a plan for you and for everyone. So X-ray shown to you, always start with the AP. Don't go jumping from an AP to a lateral. That's the message, okay? So even on a hip, don't jump from your AP hip to the lateral hip, all right? So you're going to finish one X-ray and then move to the other one. Happy with that, Ahmed?
Yeah.
So on an AP, you'll say this is an AP radiograph. Do you agree? Is it a short leg film or is it a long leg view?
Well, we have a short view of the
leg. So the correct word is a short leg view. So I want you to always know for lower limb as well as upper limb, every X-ray got a terminology which is correct. Please use that. It automatically gives you a 4 or a 5. So if it was a hip, you say it's a pelvis with both hips, or it's a pelvis, you say it's a pelvis. If it's a shoulder, you say it's a this view, that view, right? So this is a AP view, which is a short leg view.
Yeah.
Then say the most common abnormality and speak, severe significant degenerative changes. Happy with that? Then say, from what I see, on the tibial side, there is a definite tibial sublux, correct? Yes?
Yeah.
And there is a degree of a varus deformity.
Yeah.
Radiologically. Then say, my areas of suspected bone loss, use these words, is that I'm not sure, but there may be some loss on the medial side, but I feel there may be some loss on my lateral femoral condyle. Happy with that? So that's all you say. And then say, without having a history of any previous fracture above and below, I need that clarification, or I need long leg films. Just, you have to say that. You know what I mean? Because you can't not know what's happening above and below. Happy with these 5 statements for this?
Yeah.
And then you go to the lateral. On the lateral, just speak to me about the lateral.
Yeah, so again, it's a severe degenerative changes with what seems to be a lot of bone loss as well. Again,
Now, when you say bone loss, how can you say bone loss on your lateral? You normally see bone loss on a lateral?
Not in this. No, not really. No.
So laterally, no. So what do you see for? One, you see whether they are posterior osteophytes, correct?
Yeah.
So you agree there's a huge posterior osteophyte there?
That's right, yeah.
So you can say that. Do you agree that there's a significant patellofemoral arthritis? Right?
Yeah.
And do you think you can see the joints? You think there's a joint or there's no joint?
It's difficult to see on this view, but barely.
So it's very clearly a stiff knee. And I'm telling you, when this patient comes, it's maybe 0 to 5 degrees. Yeah.
Yeah.
So that's what you have to pick up. Yeah. So there is going to be an issue of it's not a fused joint. There's a degree of ankylosis. There's a significant posterior osteophytes. Yeah.
Mm-hmm.
So now, if you have to approach this knee, Ahmed. So now I'm going to ask you, thank you very much. You've clearly passed on this. Now, what will you do next?
So, as you highlighted earlier, I would want to know if this patient had any previous fractures to the proximal femur or the distal tibia. I want to know take a detailed history and perform examination history. I want to know the severity of pain, the level of mobility. I want to know if he has past medical history, diabetes.
Ahmed, for that, good you're telling me this, but I would just tell you, just because I'm trying to do this a little more as a teaching rather than your viva, if you don't mind, use a phrase that assuming this patient, I take a complete history and examination, and all conservative measures have been exhausted, and this patient does not have any definite contraindication to joint replacement surgery, my feeling is that this patient is a candidate for that. But I do agree, it comes under the realms of complex surgery.
Sure.
Yeah, so rather than saying otherwise 2-3 minutes goes away and saying, I'll take a history, I'll do this, I'll do that. Just use this phrase, assuming all exhaustive consumer are exhausted, I've taken a history, examined him, and there are no contraindication to joint replacement surgery. This patient is a candidate for that. Because you see, that's what we are doing. Thank you, Avisham. Carry on. So what are we going to next, Amit?
So I want to examine him. So assess the how stiff his knee, and that would be in terms of exposure, what difficulty I'll be facing.
Fantastic. So tell me all your problems. So exposure, yes, carry on. Thank you. Carry on.
Yeah. So exposure in terms of laxity in the medial and lateral collateral ligaments may be assessed preoperatively, but I think what will make big differences when you do it intraoperatively in this case.
Fantastic. Very good answer, Amit. Thank you for that. Carry on.
In terms of any previous scars the patient may had.
Yeah. Okay. So now tell me you told me exposure is going to be an issue, and that could be due to previous scars or the fact that it's, you know, you got this bony type of issue of a 0 to 5. So you agree the exposure is going to be an issue. Once you go in, tell me about what you're going to do next from your bony point of view. So let's go in and you don't have an issue on your femoral side. Let's say the femoral condyle is fine, right? Correct?
Yeah, so that's fine. So if once assess the exposure, my next thing is assess the bone loss. We've highlighted that there is a bone loss on the tibial side, on the medial side.
Do you think it's going to be huge? It's going to be as bad as the earlier X-ray I showed you, or not as bad?
As the X-rays previously shown?
Yeah.
I would have thought it's.
You agree this is much more and very dramatic compared to this potential one?
Indeed, yeah.
Yeah. So in your gut feeling is, yes, you're worried about it, but you know that it may not be as bad as, So remember in our talk, what are you going to use if you have to use something?
If we're worried about bone loss, we're going to use an implant with a stem and a sleeve.
Stem, yeah. So first start with a stem, because small amounts of bone loss, you agree, can be tackled by just stemming an implant, right?
That's right. Yeah.
Now, you were very right, and actually you picked it up, which I probably, I thought of it, but I didn't think too much of it. You agree on the femur as well. If there's not too much which requires a sleeve, what are you going to use?
As a
again,
stem.
You can use stems anywhere, right? So the issue with difficult knees is A, talk about where the bone loss is, B, talk about your lateral, then divide your problem into 4 parts. A is exposure. Is it going to be difficult or not? So this is going to be a difficult exposure. So say that. B, make sure that you don't missing a fracture or a deformity above and below. Happy with that, Ahmed, like you said. C is look into the bone loss, where and when, how to tackle. And 4, after I tackle that, I will check the integrity of my soft tissue envelope. And if I feel I do not need a higher constraint, I will not need a higher constraint. Ahmed, happy with that?
Yeah, that's right.
So is your gut feeling that you need constraint for this or not?
Well, I think the fact that it's stiff and ankylosed is unlikely.
Yeah, don't let that be an issue, okay? Let this issue that once you recreated your bone loss, have you got an aligned knee without any issue of the laxity? Yeah?
Yeah.
Okay, so this is what I've done. So all what you said is correct. You agree now? I put a stem on because I was a little concerned like you about my integrity of my bone on the femur. Yeah. You agree on my tibia? I put a stem on. Why? Because I was a little worried about my integrity here. See that there? Yes? But do you agree it would have been an overkill to put a sleeve? Right?
Yeah. Yeah.
And you agree once I put everything in, I did my integrity for my collaterals. It was perfect. Did I need any higher constraint? No.
No.
So I didn't. So that's how I will say. Okay, Ahmed, so I think you answered very well. Firas, you agree he would have definitely passed with a good answer?
Yeah, it was very good answer, and also your feedback was excellent, and highlighted the main positive aspects as well as how to improve the answer. And
thank you. Firas?
I had a question for the boss. With the amount of subluxation, the constraint, when you went inside, what is the state of the collaterals, Mr. Mahaluxmivala, and how did you tackle that?
You see, the sublux will be there.
Yeah.
The issue of sublux, it's there visually as well because of bone loss. All right.
Correct. Yeah.
It's there due to tightness, and most people feel, and once again, Firas, with your permission, this is a true fellowship answer. Yeah, it's not going to be tackled at the FRCS auth level, but I'll answer it for you. Is that at the true, when you see lateral sublux, but in a varus type of knee,
yeah,
those are the ones where I actually divide or do something to the popliteus tendon. So most people feel that when you're doing a popliteus tendon, it's tackled in the valgus knee. My feeling is most of the time I've done it in my complex varus knees. All right, so that's one question. And my question of integrity of collaterals is very clear. I build up, I cut where I want, I build up my bone to make my tibia and my femur where it should be without excessive bone loss. So I'll never use or insert more than 10, 12, etc. Once I do my trial, I check my integrity, and if the collaterals are fine, that is fine. It does not need higher constraint.
I agree, but when you went in this particular case, how was the collaterals? Was it, I mean, I'm sure
not
the medial collaterals.
The issue with these knees is collaterals. Well, if you ask my opinion, it was fine. The issue with this knee was due to the significant osteophytes. So nowadays, collateral, lengthening, collateral releases, all that we've stopped doing because we are now working very much on osteophytes, capsule, getting implants at the correct level, not proximalizing, not distalizing. This is where it is. So the answer is they were fine. Good question. Even I have my backup always, but in Harlow, because of Paul Allen's legacy with Dupuy and mine, we have everything on the shelf. So everything of Dupuy is on the shelf for us, so we have it.
Thank you, Mr. Mahaluxmivala. That was wonderful. I think we just, if you don't mind, we'll put on the MCQs now. For the first question, patella resurfacing offers clear advantages for TKR outcomes in evidence-based studies, and 91% of you said it's answer number 3. And yes, there is no clear evidence to support resurfacing or not. Next question, stems by their own are used in total knee replacement to provide stability in collateral ligament incompetency. 72% said it's false, and that's the correct answer. Question number 3, low viscosity cement is routinely used in total knee replacement practice, and 89% said false, and that's the correct answer. So well done everyone who answered correctly. You've been listening.
Thank you everyone. I hope that was clear. Any questions you want to, I can come back to you all later if you want. I just want to end with very glad to say one of the FRCS, the second edition has just, I think today got published. So this is a book which covers everything. All the senior authors have contributed. It's amazing. And Ruth very kindly, because like I said, she is passionate about her role in the UK for providing courses. And she's put this up as challenging cases. It's on the website, and which anyone can go in. The contributors have given these challenging cases, give your input, and then later on the surgeons who've given their input will give the answer. So this is there on the website now. There are these books which have been traditional books already available from AOR UK who they support. And lastly, really as a unit or as an entity, AOR UK does everything for non-profit making, and this is their donation. So Ruth has kindly said we could just put these up for her, and I'm very happy to do so. And thank you very much, Ruth and Firas, for this excellent day. Thank you.
Lovely, thank you, Mr. Mahaluxmivala. It was a wonderful session. It was you very nicely, comprehensively covered the total concepts of total knee replacements, a buzzword to use, how to answer questions perfectly well. We have all used your methods of answering these questions, and they worked very well for us. So I encourage everyone to try to use the same approach to answering questions related to total knee replacement. We've certainly learned a lot from you today.
Thank you.
Everyone who participated for all the questions, they've been very good, sensible questions, and they're all relevant. We encourage participation and interaction during these sessions.
Thank you so much. Thank you.
So thank you everyone. Now